Well, hello to everyone and welcome to day 4 of the AssureTrack Compounding Compliance Updates of 2021. Our session today will focus on OR satellite sterile compounding during COVID-19. My name is Tom Caracosta. I'm the VP of Strategic Marketing here at ConsortiEX, and it's my pleasure to introduce both our ConsortiEX Advisory Board member, Ernie Anderson, as well as a pharmacist who's really on the front lines of sterile compounding during this pandemic, Jevon Oliver. Dr. Oliver is the manager of perioperative pharmacy services at Mass General Hospital in Boston. To all of the attendees, I do encourage you to use the Q&A button that is at the bottom of the Zoom window for any questions that come up during the session. I'll be reading through those, and at towards the end of this session, we'll take some time to answer those questions. With that, I will hand it over to Ernie. Thank you, Ernie.
Yeah, thank you, Tom. So it's a pleasure to be here with Jevon to talk about pharmacy and what's going on, particularly in this year that has been quite a tumultuous year. People say that this has been unprecedented, and that seems to be one of those key words that people like to use with the COVID-19. So Jevon, can you give us an update on what the present state is at your facility in regard to COVID-19? Have you seen a resurge of patients coming in? Maybe even track it back to when things were at its worst back in, say, March, and then kind of move it forward, just in terms of the numbers of patients and how it's waxed and waned, perhaps.
Ernie, I'm sorry.
I can hear you.
I don't know, are you able to still see me or hear me? My laptop is freezing right now. I just want to make sure if I'm talking, you can hear me.
I can hear you, so I'm sure that other people can see you.
Okay, perfect. I just can't see myself.
Yeah, we do have your face on the screen, which is frozen.
Okay.
Minor technology problem, but we can hear you well. So
okay.
Did you get my question?
Yeah, it sounded like the question was, what are some of the things we experienced back during the beginning of the pandemic, and also kind of maybe give an overview of what we're seeing now.
Right, just in terms of the kind of the broad numbers of patients, and I just want to get an understanding of kind of that curve of what it's been like over really the past 9 months now.
Yeah, so thank you for that question. As you all know, this is nothing that any of us could have foreseen happening. I do recall sitting in my office with our manager of infectious diseases back in December when he showed me, hey, Jevon, look at this new unknown disease that they're experiencing in China. And he showed me some of the videos, and I was like, oh my gosh, that would never happen here. And now 9 months later, as you all know, we're in the thick of everything. So I was completely wrong. And I told my colleague, I apologize for never believing him, or not believing him that day. So anything he says now, I take 100% to heart. So as you all know, like many hospitals back in the beginning of the pandemic, we experienced a surge in patients that led us to open up some new ICU units, building Omnicell cabinets. In the OR specifically, we were wondering how we would distribute medications in a safe manner. So we came up with some COVID kits. And also I had to redistribute some of my staff, my perioperative pharmacists, to cover some of the ICU units as we converted some of our PACUs to ICU units. And I would say as a pharmacy leadership team, my colleagues in compounding had increased batches that they had to start making. And then also we had to open up several new Omnicell cabinets on our floors as we continue to convert ICU units, and also utilize some of our residents for staffing and triage some of the pharmacists who did have ICU experience with staffing. And I would say now that we're back to sort of maybe not as bad as it was back in March, we are looking at doing all of those things again, but at least this time we have sort of a playbook that we can follow.
Okay. And as I understand it, I do believe that Mass General also developed and worked with the state to develop an alternate site as well in case there was overflow. Were you involved with that at all?
Yeah, I wasn't directly involved in that, Ernie. One of my colleagues was involved with sort of serving as the director of pharmacy of that area. He was tasked by our chief pharmacy officer to oversee that facility. And it sounds like, back when the first pandemic started, there was a little bit of use for that facility, but it wasn't truly I was glad we had it, but over several weeks after, back in the beginning, it was eventually closed due to low patients, which was good. That means we were doing a good job of handling our census. And it sounds like this time too, across the Mass General Brigham system, they're doing a better job of making sure that patients are allocated equitably amongst all of our hospitals. So, one hospital is not suffering in silence while the others are not seeing that large of an increase in number. Now we know as we all live in the city, logistically, it's hard to transport patients in those various areas. So I'm not involved, that's ways several levels above my pay grades for how those decisions are being made. But I do know that they are doing a good job of making sure that one hospital is not overwhelmed while the other hospitals are operating in normal state.
Okay, so now let's talk about how the waxing and waning of patients really affected the compounding of sterile products, both perhaps in the OR as well as in your central pharmacy. Thinking about at the peak in last March, and then things kind of dropped off, and now they're coming back up again. So how does that impact the compounding of sterile products, and whether you outsource things or insource things? Can you just kind of take us through the timeline of what's happened on that front?
Yeah, sure. So I think my colleague Paul Baker spoke about this a little bit yesterday, who's our compounding compliance coordinator, where he talked about how we as a pharmacy department decide what we're going to insource versus what we plan to receive from a 503B or 503A pharmacy. And a lot of that consists of, one, do we have the proper data to do some extended dating? Do we have the space to hold the products if we don't have the ability to do the extended dating? And, we constantly have to remake things based off of USP's expiration measures for those things that don't have stability data or the proper data for us to follow in the literature. And then we also look at our staffing levels too. So for me personally, being over the perioperative satellite, when the original pandemic started, of course, there was mass case cancellation. So we saw a dramatic decrease in the amount of irrigations that we prepare for our surgery colleagues, which is mostly the bread and butter for what we are making in our periop satellites. So what my team was able to do was assist our batching pharmacy with some of the batching processes that they had downstairs that they were, of course, getting slammed when the COVID pandemic first happened. And so we assisted with making the batches of Precedex that we compound internally. So right now we're seeing increases in the amount of Precedex that we're seeing. Of course, there's one of my colleagues who manages our compounding area started a subgroup with nursing to figure out, can we maybe rely on some of these extended infusions? What kind of concentration changes can we make to make sure nurses aren't entering the room as often? And this is nothing that is special to MGH. I think we've seen literature and a lot of information on the message boards of hospital pharmacies across the country working on these initiatives as well with their nursing colleagues. So I would say as of now, we are starting to see some of that increase happening again. We're seeing more hydromorphone infusions. Of course, we were running into, with our supply chain colleagues, we're thinking about what drugs do we may need to stock up on, what drugs do we have left from the first pandemic that we still haven't been able to use all of. So I think now we're starting to see more infusions of those neuromuscular blockers, more infusions of things like hydromorphone, Precedex, the standard medications that you've seen used across the country for keeping patients intubated. We are currently seeing an uptick in those once again.
How about dexamethasone?
Dexamethasone, that we never really ran into any issues with problems here. We of course stock those in all of our first drawer trays because they're used by anesthesia, but that has not come up on the radar as far as us hurting for any supply for those. I can't remember seeing too much in the literature on the message boards about other sites struggling with that. We did, back in the beginning when they were saying, H2 blockers is the cure for COVID. Hurry up and get some, your Zantac or your famotidine. You would see dramatic increases in purchases of those products, and I believe the same happened with dexamethasone. But I think now that, being that there's a lot more literature, we've been studying this for a year. It seems departments are a little bit more cautious before they buy up something that is in the news about this being the breakthrough therapy. I think now everyone's focus is most likely on the distribution processes for the vaccine.
Mm-hmm. Mm-hmm. So I'm sure you have protocols that have been in place now for several months in terms of treatment. Yes?
Yeah, again, my colleague who works in infectious diseases, he sends out an email anytime something changes or if we have a clinical trial that is new and what the parameters are for that. So I would say we have a hefty amount of guidances that the department has to stay abreast on, but luckily we have a robust system internally for our infectious disease pharmacy team to send out those updates when they do occur for all of us to review.
Yeah, one of the things that I saw across the country was when in March and April, when COVID was at its peak initially, most hospitals just completely shut down their ORs. So they were not doing any elective surgeries and really focused on the COVID patients. And then hospitals were bleeding red ink. You know, they were just having tremendous problems financially as a result of really cutting the bread and butter of operative services, you know, orthopedics and whatever else. And so then that as the COVID went down, then the surgeries kind of ramped up again. So I'm a little bit curious, now that COVID is ramping up a little bit at your facility, how is that impacting other operative services?
Yeah, sure. That's a great question, Ernie. So back in the beginning, when basically all cases shut down, that was difficult to figure out how to staff and where my staff could go to assist. Because as you know, there were OR nurses that were being sent to the surgery floor. So those surgical nurses could go to the ICU. So it was a lot of that sort of moving around. Then also making sure, you know, how do we continue to staff our areas for the amount of ORs that were still open for those inpatients who require surgeries. So I would say now, I think it's no secret that Governor Baker released a statement earlier this week for Massachusetts that, you know, hospitals have to do their best to decrease the amount of cases that require inpatient stays by 30%. So there's a lot of work going on now. Again, several pay grades above me, so I'm not the most privy to the information, but there's a lot of work happening internally to figure out how we are going to accomplish those measures. And I don't foresee us going back to where we were before, where cases pretty much stopped. I think there is going to be some sort of happy medium where we are complying with state regulations, but also making sure that we're taking care of those patients who may have deferred treatment back during the original pandemic and are now at a state where they have to have their procedures completed to make sure that their livelihood is not impacted. So again, several pay grades above me, I believe that is all being figured out. Then I'll wait until the charge comes down to me to figure out what I need to do to staff my areas and support those initiatives. I think one of the things that we're looking at now are what omnicell cabinets do we need to build out for those PACUs that may turn into an ICU? Do my pharmacists take care of those critically ill patients, or do I decant my pharmacist to cover the surgical floors and take that on in addition to the PACUs and the pre-op areas that we currently service? And so then they can backfill one of those surgery pharmacists to the ICUs who may be PGY1 trained and have had some ICU rotations or has done their due diligence to make sure that they are competent to provide care for those patient populations. So I think that's the state that we're at right now. But as we know, these things move very quickly. So by next week, I could be singing a different story. If you ask me, I'll have everything planned out, all my I's dotted, T's crossed. But as of now, we are in the more earlier stages of planning for those phases.
Yeah, it certainly sounds quite a juggling process to keep.
I will say, I think the one thing, Ernie, that I have, you know, we were always taught that to don't let a good crisis go to waste. I think that, you know, not that I hate saying the good thing because there hasn't been much good that's come out of 2020, but one of the things that has been very eye-opening for me, and I'm sure a lot of my colleagues at various institutions, is it does show a system can get things done quickly when all of us are thinking the same and we remove some of the red tape that normally prevents us from doing good work quickly. So it has been exciting to see how fast an institution like MGH and the Brigham and the other big hospitals in Boston can make these changes and work together to provide exceptional care for our patients.
So along those lines, I guess, do you have processes and protocols that you can like flip on and off, you know, sort of turn on a dime, that have to do with, I don't know, your workflow needs of compounding, I don't know, other automated processes that really will allow you to ramp up and then to de-escalate?
Yeah, we'll say from a compounding perspective, as Paul mentioned yesterday, we do use a lot of IV electronic software that gives us a ton of data to see, you know, where we may be suffering, what infusions are we compounding a lot of, like what do the numbers say. And as an operational team, we have a dashboard now that our boss had us create maybe 4 or 5 months ago that lists the statistics for each of our areas. So I will say we do have the data at our fingertips to figure out where people can go, what can we do a little bit less of? Maybe back to your earlier question, what can we consider sending to a 503B pharmacy or obtaining from a 503B pharmacy that'll open up, give us leeway within our current workforce to move people around. So that information does help a lot with making those types of decisions. But again, we also have to listen to our staff to see where they may be hurting, because numbers look good on spreadsheets and paper, but it's always nice to hear from the folks who are doing the work themselves and obtaining their ideas for where some inefficiencies or efficiencies may lie as we do our best to take on this additional workload that we do see with this COVID patient population.
So what's the absolute current status? Like, what's going on today?
I would say today, Ernie, we're all still in limbo. We're still doing our day jobs while also dealing with the vaccine coordination and also making sure that we have the planning efforts in place for COVID patients. So I would describe today's workflow, even my day today, as dynamic in that sense. So there's a lot going on. Again, several pay grades above me. There's a lot going on in my pay grade. I'm meeting with my staff to answer their questions and to keep up with emails and just make sure that communication is the best thing. Because as you mentioned, we do know what worked well the last time, but and we do know a lot more about the COVID virus itself. So I'm not feeling as anxious and nervous as I was previously, because at least now I have a playbook where I can look at, things may not have gone well. I didn't do things perfectly. I myself have never been through a pandemic. I wasn't here when the Spanish flu was happening. And then also was still in pharmacy school when the H1N1 virus was occurring. So this is my first time being in a managerial role during this sort of global pandemic, or even before when it was more of I think the proper term is an endemic. So I don't have all the right answers, but at least I have something to look at to see what we did the last time and discuss with my staff what worked well, what didn't. We debriefed after things turned back to normal. So I will say the good thing about this second phase is the anxiety of what is to come is not truly all the way there. Like, we're all anxious. I think we're all baseline anxious throughout the entire year of 2020, if I'm, can speak freely. But at least we have something to fall back on this time, which is nice.
Yeah. So I'm just curious. So in the area of compounding sterile products, do you use like master formulations and SOPs and things like that again are great references for people to turn to as you're shifting people around and having to meet the immediate needs as they arise very quickly?
I think the good thing, and I was fortunate enough to attend Paul's talk yesterday with ConsortiEX. He did mention how with his role, we are standardizing the training efforts for all of our compounding staff to make sure that we're all practicing in the same manner. Now, as you know, things change very quickly. So in some of our areas, we've implemented IVX, so some of the technicians aren't as nimble with IVX, but the good thing about those technicians is they're still very familiar with the compounding processes that we had in place prior to going live with that additional software, so they can move and do things that that in those other areas that aren't live with that systems. But for instance, if my technicians do need to go down and help our batching pharmacy or help with our on-demand products, they're not familiar with the IVX system, so they would have to, of course, receive training. But I do think with the standardization of our master formulary records, our SOPs, we all practice in the same manner in each of our satellite compounding pharmacies, which is great from a regulatory perspective. And then, having Paul's role, he's helped tremendously with making sure that we are all going through the standard training processes in each of our compounding satellites. So we do have the capability to move staff around in various areas if the need is there, and not have to spend a ton of time training them or worry about any downstream safety issues because of differences in practice.
Okay. No, that's great. Well, let me.
I promise Paul's not paying me to give him all these shout outs. I truly do love his role and appreciate what he's done for our institution.
Yeah, no, I enjoyed talking to Paul yesterday. I actually had a conversation with him this morning as well. And we talked a little bit more about his role within Mass General. And, I'm sure he appreciates your accolades. So let me bring Tom back in the picture here, and we'll see if we have any questions from the audience out there.
Thank you, Ernie. Just a couple of questions that came in today. Jevon, one of the items was in relation to going back to the supply chain disruptions that may have been caused from COVID-19. And can you talk about any additional waste that may have been caused as a result of purchasing, let's say, different sized vials as a result of those supply chain disruptions, and how your institution handled that with regard to, that additional waste, or if you plan to do any additional changes in the future?
No, that's a great question, Tom, and I appreciate the participant asking. So I'll answer that in two parts, one from the OR perspective, then one from the overall supply chain perspective. So back during the initial pandemic, there was a lot of, we didn't know this virus. This truly is why it was called a novel coronavirus, because we had no idea how it was. We had an idea of how it was transmitted, but we didn't know the transmission rate from fomite. So when we first started our planning efforts, the idea was to make a kit that would be used in the ORs, and it would contain what the providers, all the non-narcotic medications that providers would normally use to care for their patients during a single day's cases. And when we were in the initial discussion phases for that kit, the question was raised, Jevon, can we just use the kits, but then toss all the medications just in case there was some exposure? And, it's a tough question to answer, right? Because yes, I don't want anything coming back to my staff that would maybe potentially infectious, but from a judicious standpoint, I feel terrible wasting viable medications just because, we weren't really sure how we could properly decontaminate them. So we ended up saying, it's provider discretion. If you feel like the vials were compromised, throw them away. But if not, we have this solid process for spraying down all of our trays, spraying down the kits with the agent we identified as quickly killing the virus or inactivating the virus. So we didn't really see too much loss or waste in that regard. We probably saw a little bit, but not anything significant. And then we are still using some of the bulk supply that we did purchase back during the original pandemic now, and I would say that supply is being used through regular streams, whether we are maybe change our compounding processes a little bit to use up some of the vials that we had, or things can transition to the OR if it's something that we use. So I will say that our team is doing a good job of either returning product that we ended up not needing, or finding the area within the pharmacy department where it can be used. So I wouldn't say we've seen a lot of considerable waste, because I think our supply chain manager, Ernest, has done a great job ensuring that these medications that we purchased are being used. And now, we're in the second surge. So it's good that we do have some of that bulk supply, so we're not scrambling to purchase things like we did back during the first pandemic. Sorry, that's a terrible, we're still in the pandemic, but back during the first surge.
The first surge, absolutely.
Yes.
Yeah, I think it's
COVID-1.
We have policies and procedures in place to handle these things in a way that probably didn't have at the beginning.
Mm-hmm.
As you mentioned earlier, with the elective surgeries, that you're trying to find that balance around keeping them going while still taking care of the COVID patient surge. How are you going to continue to manage those kits that you created? Is it something that you'll keep out there, or will you be modifying that moving forward?
Well, Tom, it's interesting. The kits actually did not go well at all. We tried them. They didn't go well. So what we decided to do is to create a process where we treat every single case that came through the OR like they were a COVID positive case. So we were able to maintain stocking the trays that we would normally stock in our Omnicell drawers, but the anesthesia technicians, in agreement with my team, developed a process to where during the turnover between each cases, we would decontaminate to the best of our ability all the medications within that tray via saturating them with the disinfectant that we chose as a group to be the most viable for killing the virus. And that practice is still in place today. So between every single case, the anesthesia technician team does have access to the anesthesia workstations that we stock in each room, because they replenish the supplies. Then my team, of course, replenishes the medications, but they still open the drawers and spray everything down. And then, of course, the provider, if there is any risk during a COVID positive procedure that they fear that the medication was indirectly exposed during intubation or extubation from maybe a dirty glove or something like that, they can, of course, toss the medication and then waste the medication if it's a narcotic. So that's the process we're using in current state. And then when my team is performing the tray swaps and bringing the trays back to the pharmacy to scan, we are also decontaminating them with the same disinfectant as well.
Yeah, it speaks to your point earlier of being able to pivot quickly when an organization needs to.
Exactly.
Yeah. You talked a little bit about reallocation of resources at the beginning of the first surge, and now thinking through that with the second surge. Can you talk in a little bit more detail about how many satellite pharmacies you may have completely transitioned over or kept going and just at a different volume of compounding?
Yeah, I would say from a compounding perspective, all of our satellite pharmacies with true USB 797 compliant clean areas were still being managed. So we still had folks upstairs in my pharmacy handling any intraoperative or pre and post needs for those patients that were still having surgery. Our satellite pharmacy in Yaqui was still operational, even though we probably saw a decrease in patient visits. So there was no true pharmacy that closed.
Okay.
But I will say as many folks that could, and then that's the same for our ambulatory surgery centers, we still had folks out there, but we did our best to see, if there were any technicians or any pharmacists that were, furloughed or something from their original site, that what opportunities did they have at the main campus to come and help out with what we were doing here. So I'm, proud to say that no one had any gaps in pay or weren't able to help because we had an operational need for folks to do something. So I think it was a collaborative effort amongst the leadership team, a collaborative effort amongst staff. My pharmacist trained with an ICU pharmacist for 2 to 3 weeks before they were on their own managing the critically ill patients that we had in our PACU at the time. So I would say it's important for all pharmacy departments across the country just to come together as a group and figure out where resources must best be, where the resources are and how they can best be met, and to sort of not think about themselves in a silo, because I want to make sure that my area is good and that I'm staffing and taking care of my customers, the anesthesias, allergists, the surgeons, all those perioperative groups, but I also need to make sure I'm looking at our whole inpatient area, just like Periop is doing now, and assessing how I can help out my colleagues if the work in my area is decreasing while the work in other areas steadily increases. So I would say for us, we have a weekly meeting where this is discussed. My boss is going to all these meetings at the higher levels where these things are being discussed, and does a great job keeping an open line of communication. And as a department, our CPO will most likely implement, weekly meetings next week to discuss with staff what changes are happening and how it will impact their daily practice. So I would say it's important to have an open line of communication and to constantly assess every single day at this point where assistance is needed and how that can best be met with the resources that you currently have, if you don't have the ability to maybe outsource some of those clinical coverage needs via like temp agencies or something like that.
Yeah, it's a great point to be a team player during this time. Jevon, just a general question: what about this next surge? Is keeping you up at night? In terms of your ability to, work within the confines of your job today?
Yeah, I would say this one, Tom, I'm going to be a little bit tighter on staffing due to, people have lives and babies happen and surgeries happen and people are sick. So I think for me, it's most likely still staffing. It's making sure that I can keep up the level of service that is expected of us as pharmacists and technicians in my institution, whether that's from supplies, maybe being able to answer clinical questions, having some of the more clinically advanced services that we do offer. And then also, I think for me, being in leadership, just making sure that I'm doing the best I can to answer my staff's questions and to be a good leader for them during this pandemic. So whether that's me getting feedback from them, being as visibly possible in my area, I just want to make sure that I can make their work experience as comfortable as I possibly can during this pandemic and can filter through a lot of the information that's coming towards me and disseminating the truth and what is actually happening and being as candid as possible with my employees. So I would say my responsibility lies with them. And then also educating my family. When you're the medical professional in a family, of course you get questions about what's going on. So doing my due diligence and reviewing data and making sure that I'm educating them in a what's the word I'm looking for, in a responsible manner, and discussing the things and breaking them down at a level they can understand so they can realize the importance of masking and then what the vaccination or the vaccine will mean for them, and if they should get it, which I 100% agree they should, and doing my best to answer any questions they have by reviewing the literature.
Yeah, spoken like a true servant leader. That's really well said, Jevon. So that's all the questions that I had on my end. Ernie, did you have any other follow-up questions that popped into your head?
I just have one other question. When you talk about collaboration with all of the folks at Mass General, and then even with people within the system, for instance, at the Brigham. I was just curious, Jevon, if you also had conversations with people at other systems, even outside of Boston, or I guess suppose within Boston, then outside of Boston, to see if there were some learning points that you could transfer from other institutions into what was going on at Mass General.
Yeah, I think I'm sure you're tapped into these avenues as well, Ernie, but like, the Vizient listservs, the ASHP listservs, you get those emails every single day and we read them. And I know myself and many of my colleagues get hundreds of emails every single day, but I think it's important to continue to review those and also responding, making time to respond when you're like, oh yeah, I experienced that. And we all get busy. So just making sure I'm doing my due diligence to respond to those forms and say, this is what we did here. I'm not saying this was 100% right. I'm not saying this is best practice, but this is what we did. So maybe if you tell me what you did, I can learn from that. And together we can come up with what the best practice should be. And then also, I think it's really important to publish what happened here. This is going to be a moment in history that we will all remember forever. So it's important to show what happened and to publish those things and put things out there so we can continue to help our colleagues across the country. So I really enjoyed the forum that you held a few weeks ago about OR pharmacy satellite practices in general, because that's a group that, there's not many of us out there. And if we are, there's not a method for us to all connect. So if we can get more of those type of groups happening, more folks putting things in the listservs and more people responding, I think that open line of communication will help us all as we do our best to make plans to make it through this second surge and, through many things after this. But as you know, the COVID pandemic is probably what's on the forefront of a lot of our minds.
Yeah, well said.
Excellent. Well, we've reached the top of the hour very quickly. A great discussion. I want to again thank Ernie for the questions, and Jevon, thank you so much for your time and real talk on what you've experienced, in the front lines during this pandemic. Thank you to all the participants for coming and attending, and I wish you all a great day. Thank you so much. Bye-bye.
Appreciate that. And I do apologize for the issues I was having with my Zoom. Hopefully it didn't impact the presentation too much.
No, I think everybody can hear you well. Good comments, good talk, good dialogue. So thanks so much to Jevon and to Tom.